Everyone. We are live today at Aster CMI Bangalore. We are neurosurgeons from Aster CMI. We will be talking on brain tumors. We have Dr. Ravi Gopal Varma, who is our lead consultant and chief of Neurosciences, neurosurgery, and myself, Dr. Nirmala, consultant neurosurgeon. Sir, will you start the session?
So, dealing with brain tumors is a very, very huge topic. And with 20 minutes to 30 minutes, we will not be able to cover the whole aspect. So, what we thought is we will split it and we'll have multiple such sessions in due course. And questions are welcome throughout in the session. Plus, if you have questions, it can be sent and then we can answer these questions in subsequent sessions. Or on one-to-one basis also we'll be able to answer questions. So basically I'll start with what are brain tumors. Brain tumors are tumors or tumorous cells that arise from the brain and in and around the brain and surrounding part of the brain and involving the brain. So tumors do occur in the spinal cord also, but we are taking brain tumors for this particular session. So basically a tumor is an abnormal growth, unlimited abnormal growth of cells. So if you look at it, a baby also is abnormal. It's a growth of cells, and then you have a baby at the end of 9 months. Whereas it's an organized growth with normal cells. Whereas a tumor, on the similar lines, is disorganized and is destructive to the host or the human being that is suffering from the brain tumor. So basically, there are two types of brain tumor. One is a benign tumor, which is a tumor that does not spread. It only is locally invasive. It does not spread everywhere in any other part of the body. And then we have cancerous tumors, which can either arise from the brain per se primary, or it can arise from other parts of the body and can go into the brain through blood spread or through contiguous spread. That is basically what brain tumors are all about. And see, the most important thing for a person who has a brain tumor is, first of all, how do we deal with it? What can we do about it? Is brain tumor surgery safe? Do we need to be afraid of treatment for brain tumors? These are the questions that keep cropping up. So, after years of neurosurgical experience, centuries of neurosurgical experience, nowadays we have reached a situation where it's very, very safe. Not like in the past where it was extremely complicated and the outcome was very poor. But the last couple of decades, we've seen that it's neurosurgery and brain surgery have become very safe, so as is it with brain tumors.
So some of our viewers have actually asked, how will I know if I have a brain tumor? And what are the actual symptoms that will be presented if I have a brain tumor?
So that's a very interesting question. The reason is, don't look for brain tumors and don't keep imagining things when I tell you. There are symptoms that are indicative of a brain tumor. Let's take a common symptom like a headache. Headache is a very common symptom and it is one major indicator for brain tumors. But there are lots of causes of headache. So every headache is not a brain tumor. Every headache you do not point towards a brain tumor. But if you have a new onset headache, which has never happened in your life before and you feel it's nagging, it's going on, it's better to investigate and find out and rule out brain tumors as a cause, because there are, as I told you, multiple causes of brain headaches. Then nausea and vomiting associated with headache is closer indicator towards a brain tumor. Then you can have a deficit. For example, you suddenly start dropping things from your hand. And that is also a very common feature, or unable to walk, unsteadiness in gait, that is in walking, having flashes of light when you see things. Seizures is a very common cause of tumors, because a seizure is a electrical activity that happens in the brain due to compression of brain tumor. So all seizures again are not brain tumors. There can be idiopathic seizures which has nothing to do with brain tumors, but many brain tumors do present with seizures. And when you say seizures, it's fits. You must have seen people having fits. If a seizure is followed by weakness, it's more in favor of a brain tumor, but these things need to be evaluated accordingly. Then you can have a stroke-like picture in brain tumors, and where you feel it's a stroke, but then when you look at the scan, it turns out to be a brain tumor. Many brain tumors are silent, and you might find it just as you do a scan for you have had a small accident, and they do a CT scan just to rule out there is any head injury, and then you find a tumor. So that's an incidental tumor. Again, incidental tumors, many of them need to be approached because before they become significantly symptomatic, we can remove them and see that it doesn't progress into causing problems. So I think that would be probably what we're looking at. Now, let's take one question I think probably Dr. Nirmala will answer is, why do we need to operate a brain tumor? What is the reason to operate a brain tumor? Do we need to touch it at all? Is it important to open the skull and remove the tumor?
Yeah. So basically, skull is a rigid structure, and it has mainly three components, that is the brain, the blood vessels, and the CSF. Now, anything extra that comes onto the skull becomes very difficult and causes pressure on the brain. Not only the brain, the blood vessels, and the CSF. So there is chance of the tumors compressing on the brain. And most of the times the symptoms come when the tumors compress on the structures in the brain, that is the meninges, that is the covering of the brain, where they start getting headache. When there is compression, they can have nausea and stuff like that. So the most important thing is why we have to operate is to relieve the patient of the symptoms. And what we are actually looking at is to not treat the tumor, but the patient on the whole. That means if we are operating and removing the tumor, we should see to it that whatever we are doing will be safe for the patient, and the resection will be maximum and safe.
And as she said, even another important component is to know what it is. We have a tumor, you have a picture of a tumor, but we don't know what the tumor is. And then we need to find out what the tumor is so that we can give specific treatment. The tumor could be a lesion arising from tuberculosis. It could be a cancerous lesion. It could be just a benign tumor that once it's taken off, it doesn't cause any issue. So biopsy is a very important component of diagnosis and of reason why we need to take a tumor out. And by just looking at the MRI, we will not be able to tell you what exactly is the histopathological basis of the tumor and how do we go forward. Now we have diagnosed tumor, how do we go forward? So that is why biopsy is extremely important to know. And another aspect is, once you know the biopsy, say it's a tumor, it's a brain tumor which is malignant. And if there's a brain tumor which is malignant, we're taking a small piece, 10% of it, and 90% remains. Now we have to treat that 90% with adjuvant therapy like chemotherapy and radiotherapy. So that the stress on the chemotherapy and radiotherapy to treat it is going to be very much higher than if we could remove 90% of the tumor. If we can remove 90% of the tumor, then we can treat the remaining 10% much more efficiently. That is called what we say is the bringing down the tumor load. So it's like an army. If you are a lone person wanting to fight 15 people, it's going to be difficult. So you're going to lose in that battle. But if you reduce those people to 3 or 4, then you have a better chance to overcome them than what we would have if there were 15. So that is just an example to show you that tumor load reduction is very, very important.
So one of our viewers have asked, is there any specific cause for a brain tumor?
So again, that's a very, very pertinent question, because if we knew the cause, we would have seen to that the tumor doesn't arise. So unfortunately, we have still no one particular reason why tumors occur. Multiple postulates have been made saying that it runs in the family, then sporadic, it can occur at any point, de novo, we do not know why it occurs. Certain cultures, there are certain tumors which are more common. In certain areas, certain tumors are more common. For example, in Japan, the malignant gliomas are more common because they sort of attributed to the Holocaust that happened with the nuclear bomb, Holocaust, atomic bomb. So radiation is a cause. Some people say mobile using is a cause, but we have no clear indication that these are causes for brain tumor. So, but for example, a tuberculoma, that means it's not exactly a brain tumor, but it's a lesion in the brain which looks like a tumor. It feels like a tumor because it's a mass within the brain. We know it's because of tuberculosis. The organism tuberculum bacteria go there and then they sort of form a granuloma, which is called which works like a tumor. So certain tumors we know, but most tumors we do not know why it occurs, where it occurs. A lot of research is going on. A lot of genetic research is going on to find out if there are genes specific for tumors and if we can do gene alteration and prevent tumors coming up. But that is probably in the future.
So there is one more question, sir, asking how is brain tumor diagnosed?
Yeah, so that's very important. So a moment you come into a hospital, there are multiple investigations that we can do. The gold standard investigation is an MRI brain. In certain tumors, a CT is very helpful, but a combination of the two is always a welcome thing. MRI gives us much more details of the tumor, the place of the tumor, where is it associated, which gyrus or which part of the tumor that brain that is the tumor compressing on. We can correlate the MRI with the clinical findings. So therefore, MRI is a gold standard, and we do most cases are diagnosed with an MRI. And once we correlate clinically with the MRI, with the imaging, then we would say, okay, these are the symptoms and signs that correlate to the tumor, and taking out of the tumor will result in beneficial effect on these symptoms. So that is one of the very important modes of diagnosis. Another component which adds to the diagnosis is probably an angiogram, digital subtraction angiography, where we inject a dye and find out how vascular the tumor is, so we are prepared to operate the tumor, which is an important constituent of the armamentarium of investigation. If we feel there's a tumor which looks like metastasis, which is a tumor from somewhere else, there is something called a PET scan, which we can pick up probably from where it is arising, and we'll be able to be more accurate in follow-up and subsequent treatment of these tumors.
Sir, how do we actually achieve a safe maximum resection?
So the most important thing is, as Nirmala had said before, we are operating on the patient and not the tumor. The patient is the most important part. Now the tumor has to be removed, preserving the functions of the patient as much as possible. Definitely there are patients where after removal of the tumor, the deficits might increase, but we need to minimize that increase. And how do we do that? We have to maximize a safe resection. That is the dictum that we use, maximized safe resection. So we remove as much as possible, keeping safe limits so that the patient is comfortable. Now to achieve that, we have a lot of equipment that help us both intraoperatively and immediate post-operatively, where we can see that the amount of tumors that we have removed and if it is safe. For example, there's a tumor at the speech area. So we can operate the patient on awake craniotomy. We'll be talking to the patient while operating. And as we're removing the tumor, we are constantly talking. So if we reach areas which are close to the speech area, the speech arrest occurs, we would map it first. We would map the speech area and approach the tumor and remove it without affecting the speech. Similarly, if it is the leg area, hand area, because the brain has got different representations of each of our limbs have got some representation in the brain. And if the tumor is close to that, we measure those things and count those things and then take them out. So that is one way of being very safe. Another way is neurophysiology. We will stimulate and see certain areas. For example, if the hand area is functioning post-operatively, we stimulate neurologically and say, okay, it is intact, we have not affected it, the tumor. Trying to remove the next part of the tumor might affect that, so we stop at that point. After all this, we also have post-op imaging, which is done intraoperatively. That means in the operation theatre itself, we can shift, do an intraoperative MRI, see whether we have adequately taken, is there some areas that we have missed out, and then wheel the patient back into the OR, the operation room, and remove the remaining part of the tumor. So intraoperative MRI, intraoperative CT are two diagnostic tools that help us to achieve the safe maximum resection and to prevent as much as possible any new deficit in the patient, and to also relieve him of the previous symptoms that he was suffering from compression of the brain.
So basically, the treatment for brain tumors is surgery. Is there anything else that we can offer to the patient?
So there are certain tumors, as we know, there are certain tumors in the brainstem where the approach itself is dangerous. It could cause issues, and the brain the whole tumor is very ill-defined, very it merges with the normal tissue. In such situations, we don't, do surgery. It's a very rare occasion like that where directly we might go to radiotherapy, which is called a brainstem glioma, for example, in a pediatric child. And if it's very diffuse brainstem glioma, we can give radiation without actually taking a biopsy or going in for a surgery. But apart from that, I think most brain tumors have to come out. We don't need to nurture a brain tumor because it's only going to cause problems as the tumor grows.
Can there be minimally invasive approach on brain tumors, sir?
Yeah. So when you say minimal approaches is trying to approach the tumor in a situation where the tumor is easily accessible, causing very less defect or obviously getting into opening your skull in a big way, bringing the skin down. All that can be avoided in certain tumors, a handful of tumors, where we go through the nose and then we can decompress it, and there's no scar anywhere, and we're not touching the brain, we're going below the brain. So there are certain skull-based approaches which can be done minimally invasively. We use an endoscope, we use a microscope, we can use a combination of an endoscope and a microscope, and we can use navigation for many of these things, which is again a safety profile where we can navigate without going into normal tissue. We can go directly into the shortest target, shortest trajectory to the tumor, so that we don't go through very eloquent brain area and try to remove tumor. So use of navigation in the skull-based thing can minimize the amount of craniotomy you do, minimize the amount of approach you can use safely, so that the patient can have a safe outcome.
Is there any role for fluorescein in brain tumors, sir?
So fluorescein is a dye that is given. It's a very simple dye, very inexpensive dye that is given in mainly used in ophthalmic surgery and many of the plastic surgery units. We give this through the IV about 40 minutes before we start while we are inducing the patient for anesthesia. What it does, it enhances the contrast, enhancing tumors. And when we operate with the specialized microscope that we have, there are filters by which, it's called a yellow filter, which will filter out and tell you which of the tumor is removable and which is not. And then the margin between normal tissue and abnormal tissue is seen very clearly under the microscope, and we can again safely remove it. I think it's stuck.
Stuck. Shine. Stuck.
So it can, you can make out the difference between the brain and tumor, and the tumor can be removed a little more extensively. So we extend the safe maximal resection enough to remove more of the tumor.
There is one of the viewers who have asked, what are the possible problems that I should look for after a brain tumor surgery, that is?
Yeah, so after brain tumor surgery, depending on where the brain tumor is, what the tumor consistency of the tumor is, what the diagnosis of the tumor is, there can be varied things. For example, if it's a benign tumor, once we remove, we are nearly done. There's no issues. We just have to follow up doing MRIs and follow up with anti-epileptic drugs and things like that. So we just do a good follow-up. If it is a malignant lesion, then we need to go ahead with adjuvant therapy, which is chemotherapy or radiotherapy, which will be advised by our radiation oncologists and medical oncologists who in concurrence with us, we would discuss and say, okay, this person requires this treatment, and go ahead with that. They would take care of the malignant part. But apart from that, I think having a brain tumor is something that is inevitable. You have it for a person who's already having a brain tumor. The most important thing I think we need to realize is we need to get it out, because we don't want foreign things growing in your head. And that is the most important thing of brain tumor. There are very small tumors which are asymptomatic, which does not is incidentally found. Maybe we can follow it up. For example, it's a small benign looking tumor far away from eloquent areas, and it's very small, and he's say a 70-year-old gentleman. We don't have to do a surgery. We can just keep observing, maybe monthly or yearly or annually. We can do an MRI, seeing whether it is growing or not, and then take a call if it is growing. And some of them grow at very, very slow rates, and he might outlive the tumor very easily, and the tumor will not cause any issues. So very rarely those tumors are not operated. So I think here the most important dictum is to do safe maximal resection.
Yeah.
So, yeah.
So this is from one of our viewers. Thank you, Akhila Mohan, for asking this to us. Is there a possibility for reoccurrence after surgery?
Yeah, so there are certain tumors that do recur after surgery, especially the malignant variety. There is a chance it can recur because a tumor goes like this, and you can see this is the tumor, and this is normal tissue. So there's tumor that goes with small extensions within the normal tissue. So when we operate, we remove this part, which is obviously tumor. But if you try to remove all these parts, then you cause functional damage for the patient. So we prefer not to remove those. But these can be dealt with chemotherapy, radiotherapy. Now, in spite of chemotherapy, radiotherapy, malignant tumors have a tendency to recur, and they do recur. Benign tumors, if we do not excise totally, for example, there's a benign meningioma, which is a totally excisable tumor. Once we totally excise, unlikely to recur. But if there are some tumors which will be adherent to blood vessels, which will be adherent to eloquent region, where we purposely would leave it because we do not want to add a deficit to the patient, those can recur. But we do have treatment for that. We give radiation for those tumors also. Non-malignant tumors also we give radiation so that they don't grow back. But recurrence of tumors are known, and we have at times operated 2 to 3 times to remove these recurrences to extend the quality of life.
There's one more viewer who has asked, his name is Anand Ram. Is the brain tumor life-threatening? What's the rate of survival?
So again, a very good question, because everyone thinks a brain tumor means death. I mean, that's what people think, oh my God, I've got a brain tumor, I'm going to die. No, the outcome is very good, percentage is very good. It only depends on whether it's malignant or benign. Benign tumors have 100% recovery rate. They can recover, they can live normal life, and they will not have any issues, and maybe a deficit here or there depending on where the tumor was, but otherwise the tumor doesn't recur and you can have 100% happy life. But a malignant tumor, unfortunately, there are 3 or 4 grades of malignant tumors which are, the prognosis is very bad. There are certain patients which, if you take a 5-year survival in statistically, only about 10% cross that 5-year survival. In highly malignant tumors, maybe even 100%, none of them will cross. But there are lower malignant tumors which cross and they live years together. But having said that, this is statistics. But every tumor has to be dealt with. It is life-threatening if it is left alone, and if it is removed, quality of life can be extended. And that is why this whole discussion of why safe maximal resection of a tumor is because of this one reason, that quality of life. That's what is important. You can live with a brain tumor, no issues. But if it does not affect your daily living. But if you have tumors that is affecting your daily living, then your quality of life goes down, and this important areas of the brain are affected, and you'll have an issue. But otherwise, there's absolutely a very good prognosis these days with the new technology, with the new modalities of treatment. We are able to give a very, very good prognostication.
So with this, we will try to wrap up this session, sir. So ultimately, the aim of any brain tumor surgery will be a safe maximum resection. I hope we have tried and answered all the questions that our viewers have asked us. Thank you, viewers, for joining us in this session. If you have any further doubts, you can actually drop in the queries in the comment section that has been given below, and we are always there to clarify your doubts. Thank you.
Thank you.